And therefore, I would like kindly to introduce Professor Giuseppe Rosano, the President of Heart Failure Association of the ESC, and one of the experts in the field of HFpEF. We are going to discuss today HFpEF in details. We have 4 talks, and we expect some of the discussions. The first talk will be given by Professor Giuseppe Rosano. This is a big controversy, but also the work in progress, and this is HFpEF a needed classification. Giuseppe, please.
Thank you, Peter. Thank you, Professor Seferovic, and thank you for the introduction. And I think that we've made big changes on the classification of the HFpEF, and mostly thanks to the guide that we received from Professor Seferovic that started this change during his mandate and continued thereafter. This is my declaration of interest. Now, when we look at on how we evolve the concept,
would you please
basically
share the slides with us? We don't see your slides now. We see you, but not.
I've shared them. I mean, it's and I can see that they're shared in the screen.
Yeah, we don't see them. Try once again from the beginning. That's the key.
Okay, I'll stop sharing and I'll share it again.
Okay.
So I see them
Now
appearing.
Okay.
So when we started the concept, I mean, of preserved ejection fraction, I think that there was this dichotomy between reduced and preserved. Reduced wasn't clearly what it is now. I mean, it's reduced started at the left ventricular function of 45%, and then was reduced to 40%, then 35%. And preserved was something that was very not clear. Also, there is the issue of a non-measurement error that it's inherent with the use of echo, that is usually around 5% in very experienced centers. So then in 2016 there was the introduction of mid-range, now mildly reduced ejection fraction, and that is for between 40 to 50. But again, how many really true heart failure with mildly reduced ejection fraction we see is not clear, because some of them will be patients with preserved, some will be patients with reduced. And I think the main problem is that we made it too complicated, and also to make the diagnosis of heart failure with preserved ejection fraction, we required too many tests that are often useless. But I will accept in few cases, but Professor Seferovic will touch upon it later. Now, what is important is that for the future, what probably will happen is that we will move from the classification in silos of reduced, preserved, mildly reduced, to the identification of the trajectories, more to understand how patients evolve through their left ventricular function, rather than when they stand, well, because we may have patients with preserved that then they progressively get worse, patients with reduced that progressively get better, and patients with mild range with progressively get better. And then we have a very, very small proportion of patients that stay with mildly reduced or with preserved. So I think the future is to look at trajectories more than at specific phenotypes. Then when we look at the characteristics of patients in PEF trials, we see that there's a large proportion of patients are hypertensive. You see around 90% of arterial hypertension in the recent trials. Then half of them have type 2 diabetes, and then others have other comorbidities. In 2021, the recommendations for treatment of patients with preserved ejection fraction was only to screen for etiologies, both cardiovascular and non-cardiovascular, and recommend diuretics. And this was based mostly because most of the trials conducted in patients with left ventricular function greater than 40% were negative or neutral, except for those patients included in seniors with bivalve. Now, then 4 hours after the guidelines, the 2021 guidelines were presented, then the results of the Emperor Preserved were published, and they changed completely our approach for patients with heart failure with mildly reduced and preserved ejection fraction. The study, demonstrated a 20% reduction in mortality and morbidity for heart failure. That was followed by the liver with dapagliflozin the following year, and that demonstrated the similar efficacy in patients with a very early effect. And the meta-analysis of the two studies demonstrated a clear overall benefit on cardiovascular death or first hospitalization for heart failure, on cardiovascular death, and on hospitalizations for heart failure. Therefore, and what was very new and what it became apparent with the SGLT2 inhibitors is that they are different from other drugs, as the other drugs lose efficacy with the improvement of left ventricular function. This is not the case for the SGLT2 inhibitors that have a consistent effect across the left ventricular function. For this reason, there was a need to update the guidelines, and the 2023 focused update of the 2021 guidelines basically gave a class 1A recommendation for the use of SGLT2 inhibitors to reduce hospitalizations and cardiovascular death, so class 1A for both mildly reduced and preserved ejection fraction. But still, we have the problem of comorbidities, and a position paper of the Heart Failure Association led by Stefan Anker then highlighted the importance of arterial hypertension, the elderly, the presence of atrial fibrillation, obesity, and all the comorbidities that often are the main cause of hospitalizations in patients with a left ventricular function greater than 40%. And again, when we look at trials, we see that, for example, if we look at trials with diuretics in patients with hypertension, we see that rather than the effect that we always look at into trials with arterial hypertension, which is stroke, the most striking effect was on 50% reduction of heart failure hospitalization. So the treatment of hypertension is effective in reducing hospitalizations for heart failure. More recently, we had data in the obese subset of patients with heart failure and preserved ejection fraction with semaglutide in the HFpEF trial that demonstrated an improvement in quality of life and exercise capacity with semaglutide. So you see new treatments are coming alongside the SGLT2 inhibitors, and this treatment seems to be beneficial overall, and these are data from the HFpEF trials that demonstrate a clear benefit on all the clinical endpoints, and including the number of heart failure events. So but what was important is that with the HFpEF is that this effect is not just related to the weight loss, because it's weight loss usually in patients with heart failure should be associated with an increase in NT-proBNP, because obese patients have a lower NT-proBNP, but instead in patients with included in the HFpEF there was a reduction in NT-proBNP, suggesting that this is a direct effect on patients' structural disease of the heart. So looking at therefore I think when there is a need to phenotype patients in order to guide therapy. So whenever we see a patient with heart failure and left ventricular function greater than 40, of course, dapagliflozin and empagliflozin should be the key of treatment. But then we have to look for the major comorbidities. And these major comorbidities are the arterial hypertension, obesity, COPD, iron deficiency, ischemic heart failure, and type 2 diabetes. And we know that we have treatments for these diseases and all these comorbidities that may worsen heart failure. Let's think of the short-acting beta agonists in COPD or other anti-obesity treatments. So what we did was to suggest for the patients with, for the different comorbidities, those treatments that are either effective or safe in these settings. And for example, patients with arterial hypertension, we so specifically gave an indication for indapamide and medivolo because the two drugs have shown this efficacy. Then there is efficacy for ACE inhibitors, BNAMI, MRAs, and calcium channel blockers that are safe. In obesity, there is efficacy or evidence of efficacy with semaglutide. The data with the tirzepatide are coming and suggest a benefit, at least that is neutral, so it can be used. In patients with COPD, there is clear evidence that LAMA-LABA are effective, and the beta blockers, especially the very selective one, the beta-1 selective like medivolo, very, very protective. In iron deficiency, up to 50% of left ventricular function of carboxymaltose and or iron replacement therapy should be, supplementation therapy should be considered. In ischemic heart disease, all treatment seems to be safe, and but also what is coming important in type 2 diabetes is the effect of the GLP-1 receptor agonists, as we said, for semaglutide, now that the SELECT data have been published, and the effect of finerenone. So in conclusion, what we're going towards the conclusion, what is going to happen is that we will move towards the old classification of heart failure into a classifications that will be more clinical without the silos of reduced, mild reduced, and preserved. In this aspect, the neuromodulation will will be less important as the left ventricular function increase, while the SGLT2 inhibitors will be central and should be, and the other treatments should be added according to patient profiles. So in conclusion, the diagnosis of heart failure with preserved ejection fraction should be simplified and based on natriuretic peptides and evidence of structural function disease. We will hear Professor Seferovic will for sure give you very important insights on this topic. And when we diagnose patients with preserved ejection fraction, we should start without any delay the SGLT2 inhibitors, and then other interventions should be considered based on comorbidity, sex, and BMI. Thank you very much for your attention.
Thank you very much, Giuseppe. That was an excellent overview of the recent developments in this area, giving us the insight how we are going to approach this controversial, let's say, phenotype of heart failure. We have now a little bit more audience, and I would like kindly to ask the audience, do you have any questions for Professor Lozano? You underline one important thing which will be in the center of my presentation as well, and this is treating comorbidities is probably way to improve heart failure with preserved ejection fraction. Do you believe that we are witness soon some more breakthroughs like with semaglutide in the obese phenotype of HFpEF? Or we will go slowly from something what we have now, and you were showing that excellently in giving the insight into the different phenotypes.
Well, no, I think that the comorbidities will be more and more important in the future. I think that it will take us some time before we will have specific trials for the different comorbidities. There are some that are ongoing, as you very well know, and I'm sure you will be presenting. But I think that there is a shift in the way we will think of heart failure with preserved ejection fraction. Now we have a core treatment that is the SGLT2 inhibitors. Then we will need specific studies in specific subsets to show that the benefit. Also because if you look at the EMPEROR preserved and you look at the liver, the vast majority of hospitalizations were non-cardiac hospitalizations. So this is why we have to target the phenotypes.
One important question we should think over is, do you believe that sacubitril valsartan has any role in the treatment of HFpEF? We were discussing that here with the Egyptian cardiologists, and there were some controversies. Is this really the treatment for HFpEF or not? Sacubitril valsartan in HFpEF.
I think it could be. I think it could be useful in those hypertensives. I mean, of course, it doesn't have the evidence of the SGLT2 inhibitors, and it's still very expensive to be used as an antihypertensive. I think that there's some evidence, some more evidence in women than in men. We probably have some efficacy up to 50% of left ventricular function. Above, it's more difficult to use it, although they claim that there is a benefit up to 57%. But it wouldn't be my first choice if that is the question. It would be something I would think about in those patients who have a left ventricular function that has improved, for sure, because those were patients with previously reduced. And I would think of those patients who are also hypertensives, where you can use the full dose and with very good efficacy.
Okay. If there are no more questions, I would like to thank you very much once again for an extraordinary lecture, and let's look at the future. Thank you once again.
Absolutely, in all the aspects.
Ladies and gentlemen, let me introduce myself. I'm going to present you the next topic. Next. Here. Okay, so Professor Rosano gave you an extraordinary introduction, and that is what is important today in HFpEF. In the past, let's say in the past few years, we were helpless in the sense of that we did not have the real way how to treat those patients. However, with the SGLT2 inhibitors and with some of the new data, we came to the position that we can go ahead and treat those patients much better. What is important to know is HFpEF scores are here to be assessed now in terms of how important they can be used and how important in 2024 they are for the treatment of HFpEF. As you may know, the main characteristic of HFpEF patients is depending on comorbidities in the first place. The disease is more frequent in male, elderly, African Americans, in people who are ingesting more alcohol and who have multiple comorbidities, between 3 and 5. Variable basic diseases like coronary artery disease and peripheral artery disease are prevalent in those patients. However, we are lucky that in patient who does look that to have hypertrophic cardiomyopathy, HFpEF, we may have diagnosed also amyloidosis, Fabry disease, and hypertrophic cardiomyopathy. It is also important to underline that the level of natriuretic peptides is usually much less in patients with HFpEF in comparison with HFrEF patients. According to what was said, and according to the analysis of the Swedish heart failure registry, we may differentiate several HFpEF phenotypes. First phenotype, which is around 10%, are young patients with low comorbidity burden, and prognosis of this patient is the best. In cluster 2, around 30% are patients with atrial fibrillation and hypertension, but without diabetes. Cluster 3, 25% of the patients are the oldest patients with many cardiovascular comorbidities and hypertension. Cluster 4, 15% of the patients are patients with obesity, diabetes, and hypertension. And at the end, cluster 5, older patients with coronary artery disease, hypertension, and CKD. You can clearly see that the comorbidities are agglomerating, and the prognosis of these patients is very much depending on how many comorbidities this patient have. I think that from the practical point of view, these phenotypic clusters are important because you can understand what will be the clinical course of your patient, analyzing its clinical characteristic and putting him in some of the clusters. Diagnostic challenges in HFpEF are many. And unfortunately, in the past, we can just look what we have. However, today we are able to solve this problem on the practical ground. There are patient-related and healthcare-related factors. Among the patient-related factors, atypical symptoms, which may present any of the cardiovascular disease, then the presence of the multiple comorbidities, and phenotypic variability is very frequent among the patients with HFpEF. Obviously, all around Europe and all around the world, we have different healthcare-related factors, like low level of awareness among internal medicine specialists, not to mention GPs, then evolving diagnostic criteria and very low access to the patient to the specialist in different countries at the different degrees. So, what are HFpEF score for? So these are our attempt to make the diagnosis of HFpEF not only early, but also based on some critical and objective assessment. So we have two scores, HFpEF and HFpEF algorithm. So the both scores has good discrimination and have also good model calibration, giving us the possibility to say that in the semantic term, both scores are very good and can be used in the clinical practice. However, as you know, the theory is one side and the practice is the different side. H2FPEFF score was done in United States. It is extensively validated and comprises readily available clinical data and only one echocardiographic parameters, does not include natriuretic peptides, and it's likely to be more applicable in the clinical setting where we do not have a tertiary institution. So there is a sum of 9 points. 0 to 1 point has a low probability, which is unlikely HFpEF. Then 2 to 5 is intermediate, and 6 to 9 is high probability. HFpEF algorithm is extensively validated as well. It comprises 4 steps, but the diagnosis can be made after 2 steps and includes multiple complex tests. It is more likely to be used in super specialized tertiary clinical institution because there are some things which may be done only among the top cardiology institution. So the first step is initial workup and pre-test assessment. When patient come breathless, then the clinical assessment and standard diagnostic test. And if the pre-test results are suggestive of HFpEF, we go to the second step, what is a comprehensive echocardiographic assessment and the natriuretic peptide level. In this step, we do functional, morphological, biomarker assessment of the patient, giving them the minor or major criteria points. If the patient had more than 5 points, then HFpEF is very likely. If the patient has among 2 and 4 points, the diagnostic stress test on invasive hemodynamic measurement should be done. Step 3 is a functional cardiac testing, in whom we can do a stress echo test, which is not done in every tertiary institution, which is sometimes not easy to perform, or invasive hemodynamic measurement with the right heart catheterization, which is done in most institutions for the follow-up of transplant patient and can be also used in that sense. During the any kind of stress, physical stress, the pressures in left ventricle and left ventricular diastolic pressure is rising, and if the pressure has the degree of increase enough, the diagnosis of HFpEF is also made. The most important is final etiology based on the multimodality imaging, genetic testing, and specific laboratory analysis. This etiology workup may be done with ergometry, but also in CMR. We may say that with the CMR, we got an excellent tool to rule out or to confirm ischemia, or cardiomyopathy workup with biopsy, scintigraphy, PET, and CT, in whom we may have the diagnosis of specific cardiomyopathy. Therefore, to be realistic and to be on the practical side, we may have that both HFpEF diagnostic scores have some pros and some cons. Obviously, they are providing some systematic assessment of the patient. They can be used in outpatient and clear case. And finally, they may improve our knowledge about the diagnostic yield of HFpEF. However, timely institution of evidence-based treatment can be done if the test is positive. This is something which was stated before the GLT2 inhibitors confirmation that they are very successful in this indication, but we can talk also about other different tests. Additional prognostic relevance may rely that the higher the score, the worse the prognosis is. However, there are some contraindications and some adverse views on the use of HFpEF score. They are complicated, they are time-consuming, and also there are significant discordance in HFpEF probability between two scores. Both scores have the possibility to give the significant proportion of the patient in intermediate risk category, which is not helping too much. According to this, low concordance in HFpEF score is confirmed in multinational PROMISE HFpEF study, who are having the high clinical probability of having HFpEF. 71% of the patient in HFpEF score were classified as highly likelihood, and 52% in H2FpEF score were classified as highly likelihood. Therefore, low concordance of both scores was once again demonstrated. It is also very well recognized that after the use of these scores, we may have high requirements for further assessment of the patient who are getting into the intermediate category of having HFpEF. That applies for both scores, and it is one of the major defaults of this diagnostic approach. However, in 2021, after long and fruitful discussion, the approach to the diagnosis of HFpEF was simplified and treatment-oriented. Although ESC guidelines are acknowledged HFpEF score, the simplified approach goes to the diagnostic criteria of HFpEF, which are defined in the universal definition of heart failure. And these are the symptoms and signs of heart failure, left ventricular function more than 50, with evidence of cardiac, structural, and functional abnormality, and also increased natriuretic peptides level. With this, we can start the treatment, and using this practical, relatively simply approach, our mistake will be at the level of 5 to 7%. Therefore, ladies and gentlemen, it is clear that we have the problem with the accurate diagnosis of HFpEF. However, what we are suggesting is evaluation with a simplified guideline recommended practical approach, which will not give us the answer on the specific etiologies like amyloidosis and Fabry disease, but it will help us to identify most of the patients who are having a real HFpEF, which practically may be the final goal of what we do in the clinical practice. I would like to thank you very much for your attention.
Thank you, Professor Peter, for this complicated lecture. Okay, please.
Thank you, Professor Bitar, for one of the complicated topics, complicated disease. Let us say you finished that the definition of HFpEF, that symptom and sign of heart failure plus ejection fraction,
functional abnormality, and
above,
plus
ejection fraction above 50, or structural abnormality and diastolic dysfunction with natriuretic peptide raising. It is simplified diagnosis. When I need to go to scores, because more complicated score, this is one question. And if go to the scores, the score will change my treatment, change the type of treatment.
Thank you very much for the question we all know answer of. HFpEF score, I have the historical and personal involvement in this because during my presidency, HFA produced this score, and then I presented that in United States, let's say 6 months after the score was put up, and nobody was happy with it. It is too long, it is too complicated, and it can be done only in a small number of the places in a real clinical setting. Therefore, we thought that we need to apply something which can be easily used everywhere. And this is what we come up with the discussion in the guidelines committee to use these three stuff. And we have a big help with the introduction of the SGLT2 inhibitors in heart failure. Because now, as Professor Rosanna pointed out, we know that they are working until the ejection fraction 25 until 65. So when you have the high suspicion, and this high suspicion can be 1, 2, 3, I showed you, and what you acknowledge, then you just give the SGLT2 inhibitors. The problems are 3 to 7% of the patients which will have specific forms, as I pointed out, like Fabry disease and amyloidosis, presenting with the hypertrophic ventricle. But it's still very good for the real world, and I would agree with you. I did not get this lecture because I like scores, but I was given that to give the objective location where we are now and why we should use this course. So it's more that the progresses in cardiology help us with the introduction of the drugs which are effective. And also, to be honest, all these patients who are, let's say, problematic, they go to CMR. So you can say this is something specific or this is ischemia as a consequence is mostly of arterial hypertension. So you're absolutely right. HFpEF is a complex disease, but now we have a good in our hands, good tools to treat it first and then to do the simple clinical assessment. I agree with you that the scores will not be used in many of the cases.
Any question? Thank you, Professor Peter. Next speaker will be Professor Amr Yusuf from Asyut University. نعم. لا حضرتك لا ما جاش. The title, Don't Forget the Biomarkers.
Okay. Thank you, my chairman, my audience, my colleagues. I see that I face one of the complicated disease and the biomarker one of the tough topics, but try to make, yeah. Okay, let us go. Don't forget biomarker in heart failure with preserved ejection fraction. Why don't forget biomarker in HFpEF? Heart failure with preserved ejection fraction is a major healthcare problem. HFpEF is phenotypically diverse syndrome which creates difficulty in establishing an accurate diagnosis, determining prognosis, and developing effective management strategies. HFpEF is a heterogeneous disorder developing from multiple etiology with overlapping pathophysiological mechanisms. So, as Dr. Bitar said before, we try to understand more about this complicated disease by scores, as he said. Also, circulating marker may help in diagnosis, prognosis, and biomarkers may reflect cardiac as well as non-cardiac abnormality, and their measurement often provide insights into pathophysiological process associated with heart failure. What current European cardiology, Society of Cardiology and Heart Failure Association guidelines say, احنا فين في guidelines provide a class 1 recommendation for nitric peptide for diagnosis of suspected heart failure, and nitric peptide are a major criterion for establishing diagnosis of HFpEF. And we have two definite figures. Nitric peptide N-terminal pro BNB below 125 and BNB below 35 picogram per milli, making the heart failure unlikely. And above this, making the heart failure is possible, and we have a different number as Dr. Bitar said. What is the biomarkers in HFpEF? We have many biomarkers. More of them is in practical, and group of them in research, and group of them is novel biomarker. Biomarker due to stretch and injury, like nitric peptide, high sensitivity troponin in practical now. Inflammatory biomarker like C-reactive protein with interleukin, extracellular biomarker like procollagen with metalloproteinase, vascular derangement biomarker زي nitric oxide والادرينالميديولين والendothelin, obesity biomarker like leptin, adiponectin, kidney dysfunction biomarker like cystatin, and kidney injury molecule biomarker with anemia and iron deficiency anemia, and the novel biomarker like microRNA, metabolomics, and proteomics. Natriuretic peptide, we have two natriuretic peptide, A-natriuretic peptide and B-type natriuretic peptide, BNB. BNB and N-terminal pro, BNB, has a longer duration, so he have a gold standard in diagnosis and the prognosis of heart failure. Meta-analysis of 51 studies found that natriuretic peptide have a reasonable diagnostic performance detection of HFpEF in non-acute setting and also useful tool for ruling out diastolic dysfunction. Several studies also investigated their ability on prognosis. High level of N-terminal pro-NB identify subgroup of HFpEF patients who are at highest risk for death and heart failure hospitalization. In acute setting, N-terminal pro-NB level is also considered a strong independent predictor of all cause of mortality. And we can see here that with increase in the level of N-terminal pro-NB and high sensitivity troponin, we have increase in the risk of complication. Troponin, cardiac troponin usually increase with cell death, but not all troponin release with cell death. They also increase in cell permeability. So we have some increase in troponin with heart failure. In patients with heart failure, increased level of troponin generally correlate with heart failure severity, especially in acute setting. طب ليه بيزيد في الهارت فيلير؟ due to inflammation, more hormonal activation, myocardial stretch, hypoxia, cytotoxicity. في الامبيرو بريزيرف ترايل showed that N-terminal pro-NB concentration وhigh sensitivity troponin level are associated with severe heart failure and comorbidity. It also showed treatment with empagliflozin resulted in beneficial impact on cardiac outcome independently from baseline N-terminal pro-NB and high sensitivity troponin. So, both nitric peptide and troponin is important in diagnosis and as prognosis, but in base treatment, less evidence. Other biomarker like biomarker with inflammation, C-reactive protein, inflammatory marker correlate with the presence of left ventricular diastolic dysfunction, interleukin 1B, interleukin 1 blockade with anakinra, the recombinant interleukin 1 receptor antagonist in patients with heart failure, may improve cardiorespiratory fitness and prevent heart failure hospitalization. Biomarker with extracellular matrix and fibrosis like procollagen, propeptide, circulating B3-NB level are a predictive of death and hospitalization in heart failure. Metalloproteinases like metalloproteinase 2 and 9 activity protein are enhanced in hemodynamic models of HFpEF. Galectin 3 implicated in myofibroblast proliferation and fibrogenesis with tissue repair. It may help in HFpEF phenotyping, risk stratification, and therapeutic targeting. Biomarker relating to vascular endothelium or vascular endothelial dysfunction, like nitric oxide, reduced nitric oxide bioavailability is considered to be an integral part of the inflammatory pathogenesis that results in myocardial dysfunction in HFpEF. Adrenomedulin, high adrenomedulin level were associated with a limitation in right ventricular function reserve, reduced cardiac output, and impaired exercise capacity. Endothelin 1 level increase predictive of 1-year heart failure, hospitalization, and associated with long-term mortality. In a prospective study with HFpEF patient, the dual endothelin A and B receptor inhibitor, what's called mesitine, improved HFpEF by decreasing adverse cardiac remodeling via anti-hypertrophic mechanism and by reducing stiffness. Biomarker with obesity like fatty acid binding protein associated with more death and heart failure admission. Leptin, resistant to leptin, is associated with diastolic dysfunction and the removal of sodium retention. Let us go to what's called novel biomarker. We have circulating microRNA. The numerous clinical studies have revealed unique microRNA profiles in different disease settings, suggesting their utility as a marker with diagnostic and prognostic application. The discovery of microRNA clusters that differentially expressed in HFrEF than HFpEF, making them approach to delineate the different pathophysiological pathway. But we need further research to understand their added value in diagnosis and prognosis. Metabolomics, like in HFpEF patient, displayed elevated hydroxyproline, reflecting fibrosis, elevated alanine and cysteine, reflecting a state of increased inflammation. HFpEF patient had a lower level of cyclic GMP and cyclic adenosine monophosphate, suggesting impaired cell signaling, lower L-carnitine, indicating mitochondrial dysfunction. And we measure some of metabolism, and their expression may help in understanding what is the main problem. Proteomics, in setting of HFpEF and diabetes, Hanfi et al. Using what's called SomaScan assay and the proteomic analysis of plasma from participating in TORCAD trial, and identified 10 protein with significantly different expression in patients with HFpEF and diabetes. Of these, protein M was found to mediate 72% of the association between diabetes and the risk of cardiovascular death, aborted cardiac arrest, and heart failure hospitalization. We also need more research to understand their importance. Take-home message: HFpEF is a heterogeneous disorder developing from multiple etiology with overlapping pathophysiological mechanisms. We don't forget biomarker, which may help in diagnosis, prognosis, and their measurements often provide insights into pathophysiological processes associated with heart failure. Biomarker may help in understanding the HFpEF syndrome and may help in classifying HFpEF phenotypes. Out of box thinking that biomarker may help in choosing treatment in this complex disease, further trials are needed for assessment of biomarker in HFpEF patient and their importance. And thank you.
Thank you, Professor Amr, for this lecture. Okay.
Clinical sense is most important. More patients, ejection fraction 65, 60, والبيشنت congested mid vein, sacral edema, edema both low, severe dyspnea, والدكتور اللي عمل الايكو يقول له لا انت قلبك سليم. حالات مور، رغم ان الهارت فيلير من الحاجات المهمه جدا فيها الكلينيكال، الجالوينج والبيزل كريبيتيشن والكونجستد نيك فين، ففي يعني في اعتماد كامل على اللابوراتوري وعلى الايكو. لا، الهارت فيلير من الحاجات المهمه جدا فيها الكلينيكال سنس، وده اللي اتعلمناه زمان ان الكلينيكال سنس تشخص بيها هارت فيلير.
تمام. I agree with you completely. Definition of HFpEF now, as Turbitar say, first, symptom and sign. Second, ejection fraction above and equal 50. Third is structural functional, equalifying the stroke dysfunction with increasing biomarker. No, just 3.
يعني ejection fraction was normal. The some patient ejection fraction 25% no complaint.
Okay, it is compensated, reduced heart failure ejection fraction. I agree with you. So clinical is very important. I agree.
Thank you for this elegant lecture. It's clear from your lecture that most of these biomarkers are prognostic rather than diagnostic.
تمام.
What about the pro-NB for both diagnosis and prognosis, and why this specific biomarker was not introduced in the scoring system? My question for Dr. Batter.
No, it is present. It is present, and we have certain number. يعني say that from 125 it is grade من 125 to the pro NB to 225 it is grade 600 grade.
Okay.
ياخد score. It is
So
important in scoring also.
It is both for diagnosis and prognosis.
It is the only one which is highly in guidelines. It is the N-terminal pro-NB and BNB. It is the only two biomarkers in the guideline up till now. And it is important for diagnosis and also for prognosis. في الامبيرور preserve trial which using SGLT2 inhibitor show that it is important in diagnosis and the prognosis. But in the treatment, يعني take the patient which high pro-NB and giving him the SGLT2 and leaving the lower pro-NB, no different. Don't depend the treatment on the level of the pro-NB. Not helpful in choosing the treatment patient.
Yes.
It is very important not to be confused. So what we try to say is that we have three important points in the practice. As you said, signs and symptoms, then functional abnormality of the heart combined with the increased anti-pro-BNP and BNP, because you showed beautifully the whole spectrum of the biomarkers. But what we use in practice in our hospitals is BNP and anti-pro-BNP, and that's all. And I should tell you, because we had 42 European countries analyzed how much these BNP is used in emergency room. And all of you will be extremely disappointed. We are talking about anti-pro-BNP and BNP for ages. And the percentages of use of biomarkers in European emergency room is only 27%. So it's 1/4 of all patients, they come here. And I may ask you, I know that you don't know the answer. How much is used in Egypt?
Yeah,
So
it is low because
it's no question. It's no.
very expensive for us.
I mean, I don't know also how much is used in Serbia. I mean, but there are some facts which are essential. First, they are essential for the diagnosis of heart failure, HFpEF and HFrEF, in one sense. Another sense, we are know more and more, and we are pushing the application, the use of biomarkers more and more. And we will get to the point that most of the hospitals are having that. Please.
Yes, هو البرو بي ان بي is very يعني crucial what must be done. يعني أنا حتى مرة ask question if I do echo for HFrEF and found that ejection fraction 25, it is there is need for do pro BNP or not? The answer yes. Why? Because the ejection fraction take time to increase, but pro BNP within 2 weeks it shall be diminished frankly. So this give me and the patient. Always the patient said that ejection fraction is the same, and we say to him, but pro BNP reduce 2,000 like that.
I agree with you.
Any question?
Troponin and laboratory investigation, effect or not effect, diastolic dysfunction. Most patient of diastolic dysfunction treatment as a bronchial asthma, or after that diastolic patient يبقى grade 2 or grade 3 diastolic dysfunction. What is the role of this important of troponin and atrial natriuretic peptide and all of these?
This is very important. Yes, let us see first. There is some sort of impaired function with no symptom. Now no heart failure. It is some sort of grading of heart failure, what's called AB. Yeah, B mean في structure disease for heart failure, but no symptom of heart failure. When I say heart failure, يبقى في symptoms, as I said before. It is called stage C. Let us go to diastolic dysfunction. Diastolic dysfunction with no symptom, you are now in the stage B. According to the American College of Cardiology guidelines, staging of heart failure. When there is symptom, the role of nitric peptide and troponin is very important to ruling out what is it is heart failure or asthma, because in asthma you found that the N-terminal BNP below 125 picogram per milli definite and BNP below 35 picogram per milli, يبقى خلاص exclude, it is not heart failure. If you found symptom of heart failure with BNP more than 125 and BNP more than 35 picogram per milli, يبقى you are with heart failure. More increase in the picogram in the pro-NB 600 or and BNP 100, more with heart failure severity and with diagnosis.
Okay, in simple way, diastolic heart failure with preserved ejection fraction is not a simple left ventricular diastolic dysfunction, and left ventricular diastolic dysfunction does not mean HFpEF.
Yeah.
It's clear?
Mean HFpEF when there is symptom of heart failure.
في diastolic dysfunction لكن الايجكشن فراكشن عدى فوق ال 57.
يعني هو اليوز اوف انترست في الدايستوليك ديسفانكشن لسه عليه كلام كتير، هو بيفيد قوي في الفيميل، ولو يكون الليفل اقل من 57 اكتر من 57 في الترايل ما بانش حاجه ديفينيت فور اس up till now يعني.
You arrived a little
But
bit.
SGL2 it is we have a definite finding in decreased hospitalization, so it is recommended to use dapagliflozin او empagliflozin. Until now, interest is incoming, as you say, but up till now there is no definite guidelines, not interest guidelines, but can be used in when there is heart failure and in female below the ejection fraction below 57. Above 57, we have no evidence. That's the equipment. We have no evidence up till now, but maybe in future you have evidence.
That was discussed before you came. Professor, I asked this question. You are asking him to Professor Rosano, who delivered the first lecture.
Okay.
الدكتور هاني ما جاش.
خلاص. Okay. Any question? Okay.
Thank you very much for your attendance, and thank you, Professor Peter. And to see you next year, inshallah.
Inshallah.